Obesity Ray Kar B. Kumar, Louis J. Aron 7 Definitions and Epidemiology. Obesity is a chronic condition defined as an excess of body fat or adipose tissue that causes disease. Adiposity per se is difficult to measure expediently, so the use of BMI has become common as a marker of obesity. BMI is calculated by measuring weight in kilograms and dividing it by height in meters too. A normal BMI is between 18.5 and 24.9 kg/m2, and a BMI between 25 and 29.9 kg/m2 is defined as overweight. Individuals with a BMI of 30 to 34.9 kg/m2 have Class I obesity. A BMI of 35 to 39.9 kg/m2 is defined as Class II obesity, and BMI greater than 40 kg/m2 is categorized as Class III obesity. 1 Using BMI as a measure of obesity has limitations, however, and special consideration must be given to individuals who have higher muscle mass and, therefore, have higher calculated BMI but may be metabolically healthy. The converse must also be considered, i.e., certain populations may develop metabolic disease at lower BMI levels, such as patients of Asian and South Asian backgrounds. 2 The rapid increase in the prevalence of obesity as well as its increasing economic impact have led to greater awareness of the importance of treating obesity. The American Board of Obesity Medicine was established in 2011 to serve as a credentialing body for physicians obtaining certification in obesity medicine. Obesity medicine is one of the fastest growing subspecialties, with more than 1,500 physicians certified as of 2017. The coverage of doctors' visits for obesity care by the Centers for Medicare and Medicaid began in 2012-3-4 and the American Medical Association classified obesity as a disease state in 2013. 5 Obesity is increasing in prevalence globally. Both the World Health Organization and the National Heart, Lung, and Blood Institute of the U.S. National Institutes of Health have labeled obesity an epidemic. 6,7 More than one-third, 36.5%, of adults in the USA are obese, and if obesity trends continue, 22% of people around the world will be overweight or obese by 2045. 9 Complications of obesity include type 2 diabetes, stroke, heart disease, NAFLD, and several types of cancer, all of which are considered obesity-related causes of preventable death globally. The estimated annual medical cost of obesity in the USA in 2008 was $147 billion, and the annual medical costs for people who are obese were $1,429 higher than those of normal weight. 10 The total cost to treat all conditions related to obesity, including medical costs plus obesity's impact on work productivity and absenteeism, is greater than $1.4 trillion annually. This is more than twice the amount the USA spends on national defense. 11 Etiology of obesity. Obesity largely results from an imbalance between energy intake and energy expenditure. This imbalance may be caused by several factors including diet, physical activity, in utero influences, effects of medications, and other complex interactions between genetic and environmental contributors, including the impact of the intestinal microbiome. Genetic factors clearly play an important role in the development of obesity, and several genes have been implicated in influencing body weight, although the rate of rise of the obesity epidemic is more than genetic forces can explain. See later. Dietary factors. The global food supply has changed significantly over the past several decades. In addition to an increase in portion size, there has been an increase in consumption of refined carbohydrates, saturated fats, and salt. Sugar-sweetened beverages and fast food service are now easily accessible all over the world, including in emerging market countries where overweight and obesity-related complications are rising. 12 In the coronary artery risk development in young adults study, subjects who entered the study reporting higher fast food intake were, on average, 13 pounds heavier than subjects who consumed lower amounts of fast food. 13 The Non-Communicable Disease Alliance estimates that low intake of fruits and vegetables is estimated to cause about 19% of GI cancers, approximately 31% of coronary heart disease, and about 11% of strokes. 14 There are two conflicting schools of thought on whether all calories from different macronutrient classes contribute to obesity equally or whether certain eating patterns and dietary macronutrient compositions may contribute more to obesity than others. The calorie is a calorie concept is supported by the law of thermodynamics and by many controlled laboratory studies in which altering the percentage of calories from fat, protein, and carbohydrate in the diet does not impact weight loss or weight gain. 15 The conflicting argument that macronutrient composition matters is supported by studies in which people are allowed to choose their food freely. These studies favor a high-protein, low-carbohydrate diet for avoidance of excess weight gain. The reasons high-protein diets may be favorable are increased satiety, increased thermic effect of food, and improved body composition. 16,17 The obesity epidemic has gotten worse because Americans have reduced their dietary fat intake and increased their intake of high glycemic carbohydrates, rapidly digested carbohydrates, such as white potatoes, sugary drinks, processed cereals. 18 Carbohydrates in the form of whole grains, especially the less processed and more slowly digested grains, may prevent weight gain. These less refined carbohydrates like barley and brown rice have more evidence for a weight control effect than do carbohydrates from fruits that are rapidly absorbed. 19,20 Physical activity factors. Physical activity has gradually decreased at home and in the workplace, with a resultant reduction in energy expenditure. During the past 50 years, the increasing use of energy-sparing devices in the workplace and at home have reduced energy expenditure and contributed to weight gain. A decrease in physical exertion at work, increased driving in cars, and children rarely walking or biking to school have all been implicated in the rise of obesity rates in adults and children. 21,22 In the Nurses' Health Study, after adjustment for age, smoking, exercise level, and dietary factors, every 2-hour increment spent watching TV was associated with a 23%, 95% CI 17% to 30%, increase in obesity and a 14%, 95% CI 5% to 23%. Increase in the risk of diabetes. 23 The effect of watching TV on weight gain is likely a result of an increased caloric intake that occurs as people watch TV, rather than just the simple aspect of being sedentary. In utero and maternal factors. The intrauterine milieu and events that take place during gestation can influence postnatal weight, body composition, and the likelihood of developing obesity. These include pregestational maternal obesity, maternal smoking, and gestational diabetes, all of which increase an individual's risk for increased body weight and diabetes later in life. 24 Offspring of mothers who smoke during pregnancy are at increased risk of weight gain in their first decades of life, as are infants of mothers with diabetes and small for gestational age infants. 25,26 Medication-induced weight gain. Several commonly prescribed medicines can contribute to abnormal weight gain or interfere with patients' ability to lose weight. Table 7.1. These medications include antipsychotics, e.g., olanzapine, clonazepine, antidepressants, e.g., the SSRI, paroxetine, antiepileptics, e.g., valproate, gabapentin, insulin and insulin secretagogues, e.g., thiazolidinediones, glucocorticoids, progestational hormones and implants, oral contraceptives, beta blockers, and others. 27 If possible, these medications should be substituted by other medications that are weight neutral, or agents that can treat the underlying condition and cause weight loss at the same time. Use of over-the-counter medications and supplements should be reviewed. Medications that could interact with anti-obesity pharmacotherapy, such as the pseudoephedrine in cold remedies, should be discontinued if stimulants are used for weight loss. Smoking. Smokers have lower body weights than non-smokers, and cessation of smoking is generally associated with weight gain. 28 Two explanations have been offered for the effect of smoking on body weight. First, smoking is thermogenic, that is, the metabolic rate during the act of smoking is higher than when the subject is not smoking. Second, smoking reduces hunger and changes taste perception, so smokers tend to eat less. 29 Microbiome. The intestinal microbiota consists of trillions of microorganisms that can affect obesity, presumably via bacterial metabolism of ingested nutrients. through bacterial metabolites, such as short-chain fatty acids, or by an immune response to structural components of bacteria. See Chapter 3.30. The importance of the microbiome in obesity is suggested by studies of the coprophagic transfer of fecal material from congenitally obese, OB/OB, mice to germ-free, non-obese mice, in which the recipient mice are shown to subsequently gain weight. 31. Similar studies have also been performed in which stool has been transferred from humans to mice. In one such study, 32 separate groups of germ-free mice were colonized with the fecal microbiota from each member of 4 twin pairs discordant for obesity or with cultures from an obese or lean CO twin. Transplantation of feces from the obese kitwins resulted in significantly greater increases in body mass and adiposity than did those of the lean twins. Differences in body composition were correlated with differences in fermentation of short-chain fatty acids, increased in lean twins, and metabolism of branched-chain amino acids, increased in obese twins, among other differences. CO housing lean and obese mice, thereby enabling sharing of intestinal microbiota, prevented development of increased adiposity and body mass. Intestinal microbiota populations and murine phenotype were diet-dependent, revealing that transmissible and modifiable interactions between diet and microbiota influence host biology. The fecal microbiome of obese individuals has increased numbers of firmicutes, whereas stools of lean individuals have more Bacteroidetes and Akkermansia. 33. The proportion of these organisms in the feces is affected by genetics, see later, as well as diet. Bacteroidetes content increases to a greater degree with a high carbohydrate diet than with a low-fat diet, LFD. 34. Future studies on the human microbiome will need to be performed in order to understand how medical intervention can influence this factor on body weight, insulin resistance, and risk of obesity. Genetics having a family history of obesity substantially increases an individual's likelihood of developing obesity. The biggest risk factor for obesity in a child is having a parent or first-degree relative with obesity. Having a first or second-degree relative with type 2 diabetes is also an independent risk factor for insulin resistance. Although the risk of developing obesity has a strong genetic component, single gene defects are responsible for the obesity phenotype in less than 2% of cases. 35. The melanocortin 4 receptor, MC4R, gene, leptin gene, proopiomelanocortin, POMC, gene, and agouti gene all have significant effects on body fat and fat stores. Genetic abnormalities in MC4R may account for up to 6% of cases of early onset. 94. Part 2 Nutrition in gastroenterology. Severe obesity in children. 36. Absence of leptin or an ineffective leptin receptor is associated with severe obesity in rodents and humans. 37. Leptin has the dual effect of reducing food intake and increasing energy expenditure, both of which favor loss of body fat. Treatment of leptin-deficient children with leptin decreased their body weight and hunger, indicating the importance of leptin in normal subjects. 38. Heterozygotes for leptin deficiency have low but detectable serum leptin levels and increased adiposity, indicating that low levels of leptin are associated with increased hunger and gain in body fat. 39,40 Although genetics accounts for approximately 10% of the intestinal microbial taxa, Christensen-Lace is a highly hereditable taxon. Associated with leanness, genetic obesity-associated taxa are an area needing further research. Testing for monogenic causes of obesity should be considered in the pediatric population when early onset or syndrome obesity is noted. Table 7.2 shows other genetic syndromes that can have obesity as a component of their clinical presentation. 41 Prognosis of obesity. Obesity has a tremendous impact on the physical, mental, and psychosocial aspects of the lives of children and adults who are suffering from this disease. In a meta-analysis of 97 articles reporting on hazard ratios for all-cause mortality in relation to BMI categories, people with obesity of all classes relative to normal weight individuals have higher all-cause mortality. 42 In one study, patients with severe obesity, BMI 40 to 50, had reduced life expectancy by about 10 years, which is similar to the effect of lifelong cigarette smoking. 43 A study using National Health and Nutrition Examination survey data found that, compared with adults of normal weight, adults with class 2 and 3 obesity died 3.7 years earlier, all-cause mortality, and adults with class 3 obesity had cardiovascular disease, CVD, related deaths 5 years earlier. 44 Both primary and secondary prevention of obesity can improve life expectancy and comorbidities. Modest weight losses of 5% to 10% are associated with significant improvements in CVD risk factors such as hypertension, hyperlipidemia, and glucose control. In an observational analysis looking at participants of the Look Action for Health in Diabetes study, subjects who lost 5% to less than 10% of their body weight had increased odds of achieving a 0.5 percentage point reduction in hemoglobin A1c, a 5 mmHg decrease in diastolic blood pressure, a 5 mmHg decrease in systolic blood pressure, a 5 mg/dl increase in HDL cholesterol, and a 40 mg/dl decrease in triglycerides. 45 Pathophysiology of obesity. Body weight and fat mass are subject to homeostatic control. In the disease of obesity, there is a disruption of this homeostasis. Table 7.1 Drugs that may promote weight gain. Drug class associated with weight gain. Alternatives associated with less weight gain, weight neutral, or inducing weight loss. Antidepressants: nortriptyline, amitriptyline, paroxetine, citalopram, mirtazapine, floxetine, greater than 1 year, sertraline, greater than 1 year, floxetine, 1 year, sertraline, 1 year, bupropion, can induce weight loss. Antipsychotics: clozapine, olanzapine, risperidone, quetiapine, lithium ziprasidone, aripiprazole. Antiepileptics: gabapentin, pregabalin, valproate, carbamazepine, topiramate, zonisamide, lamotrigine, levetiracetam, phenytoin. Anti-diabetic agents: insulin, sulfonylureas, thiazolidinediones, metformin, glucagon-like peptide 1, GLP-1, receptor agonists, DPP-4 inhibitors, SGLT2 inhibitors, pramlintide. Antihypertensives: prazosin, doxazosin, terazosin, metoprolol tartrate, propranolol, carvedilol, nebivolol. Contraceptives: depo, medroxyprogesterone acetate, combination oral contraceptive pills, older generation, copper IUD, low-dose combination oral contraceptive pill. ODC: cold remedies, diphenhydramine use for as short of a duration as needed. Steroids, glucocorticoids, progestins use slowest dose of glucocorticoids needed to control underlying disease. Table 7.2 Genetic syndromes with obesity. Syndrome name, clinical presentation, genetic mutation/inheritance. Albright: hereditary osteodystrophy/ pseudohypoparathyroidism. Type Ia: obesity, mental retardation, brachymetaphyllangism, short stature. Missense, frame shift, nonsense, splice site, deletions, insertions in NOS1/NOS. Autosomal dominant Alström syndrome. Childhood obesity, insulin resistance, and type 2 diabetes. Mellitus, blindness, hearing impairment. Frame shift, nonsense, missense in ALMS1. Autosomal recessive Bardet-Biedl syndrome / Loren-Simon Bardet-Biedl syndrome. Obesity, retinitis pigmentosa, renal malformation, polydactyly, mental retardation, hypogonadism. Missense, nonsense, splice site and frame shift mutations in BBS1, BBS2. Autosomal recessive Carpenter syndrome / acrocephalopoulos syndactyly. Type 2 obesity, umbilical hernia, soft tissue syndactyly, congenital heart disease, mental retardation, hypogenitalism. Truncating, missense, nonsense mutations of RAB23. Autosomal recessive Prader-Willi syndrome / Prader-Labhart-Willi. Obesity and hyperphagia, failure to thrive, hypotonia, genital hypoplasia, mental retardation, small hands and feet. Deletions, mutations, loss of paternal allele MKRN3/ZNF127/MAGL2. Autosomal dominant, X-linked from KRY, De Souza R.J., Gibson W.T., Mayer D., A Systematic Review of Genetic Syndromes with Obesity. Obes Rev 2017, 18, 660334. Chapter 7 Obesity 95-7 as a result of impaired neurohormonal signaling. There are two bodies of neurons in the arcuate nucleus of the hypothalamus that integrate information from peripheral signals coming from the fat cell, intestine, and pancreas in order to regulate appetite and energy expenditure through thermogenesis. One body of neurons expresses the orexigenic peptides neuropeptide Y and a glutarated peptide, each of which function to increase food intake and reduce energy expenditure. The other body of neurons express POMC and cocaine and amphetamine-regulated transcript, which are anorexigenic peptides that lead to a reduction in appetite and increase in energy expenditure by activation of downstream pathways, such as activation of MC4R in the paraventricular nucleus of the hypothalamus. 46 Damage to POMC neurons and concomitant inflammation has been associated with diet-induced obesity and resistance to weight-regulating hormones including leptin and insulin. 47 This physiologic disruption is but one example of how the pathways regulating body weight are affected in the disease of obesity. Intestinal peptides, including glucagon-like peptide, GLP, CCK, pancreatic polypeptide, and polypeptide YY, reduce food intake, whereas ghrelin, a small peptide produced in the stomach, stimulates food intake. 48 Metabolism of fatty acids in the brain may be another important control point. Oxidation of fatty acids modulates activity of 5-adenosine monophosphate kinase, an enzyme that is activated or inhibited in relation to the ratio of adenosine monophosphate to adenosine triphosphate and is thought to be the underlying central point in the control system of food intake. 49 Clinical features and diagnosis of obesity. History and physical examination. Taking a history in a patient with obesity is complicated because of the multifactorial nature of the disease, which can span an entire lifetime, from in utero factors to job-related stressors and hormonal changes that occur as people progress through life. The elicited history should address age of onset of obesity, minimum adult weight maintained for a year, and notable events associated with weight gain, e.g., cessation of smoking, pregnancy, menopause, medication use. A history of psychiatric illness or of eating disorders such as anorexia, bulimia, or binge eating disorder usually requires close follow-up with a mental health practitioner in addition to the obesity medicine specialist. The care of significant alcohol and substance abuse should take precedence over obesity treatment. A detailed history of smoking and smoking cessation should be included, because smoking cessation can result in weight gain or thwart attempts at weight loss. A detailed history of a patient's current level of physical activity, including lifestyle and structured exercise, should be documented prior to initiating an exercise program. Finally, an assessment for sleep disorders including snoring, sleep apnea, and daytime fatigue or morning headaches should be obtained. A comprehensive physical examination should be performed to evaluate causes of obesity, as well as the complications of this disease. Height and weight should be measured, and the BMI calculated in order to categorize the class and severity of obesity. Waist circumference should be measured with the proper technique at the level directly above the iliac crests, especially in patients with a BMI greater than 25 to 35 kg/m2 who will require further risk stratification. 50 Blood pressure should be measured with an appropriately sized cuff to avoid mismeasurement by cuffs that are too tight or too loose. Other findings to note include the presence of acanthosis nigricans and skin tags indicative of insulin resistance, violaceous striae and dorsocervical fat pads indicative of hypercortisolism, and thyromegaly and delayed reflexes as signs of hypothyroidism. Obesity may be part of the clinical presentation of other endocrine disorders such as polycystic ovarian syndrome, Cushing syndrome, hypothyroidism, and acromegaly. Insulin resistance and hyperinsulinemia in the months or years before developing overt type 2 diabetes can lead to significant findings. Some findings such as fungal skin infections, lower extremity edema, and foot deformities may occur in patients with long-standing obesity. Certain obesity complications may manifest only with laboratory and investigational testing. A hemoglobin A1C, fasting blood glucose, or 75 grams oral glucose tolerance test should be considered to screen for type 2 diabetes. 51 A full lipid panel including fractionated lipoprotein levels is required in order to assess for genetic disorders of lipid metabolism such as familial hypercholesterolemia. Hyperuricemia, hepatic steatosis, and cholestasis are often only discovered upon further laboratory testing. Therefore, a complete laboratory evaluation should include blood glucose, uric acid, BUN, creatinine, ALT, AST, total and direct bilirubin, alkaline phosphatase, total cholesterol, HDL cholesterol, and LDL cholesterol, TGS, complete blood count, thyroid stimulating hormone test, and urinalysis. Fasting serum insulin and glucose test values can be used to calculate homeostatic model assessment levels of insulin resistance by using an online calculator based on a well-validated equation to measure insulin resistance. 52 Measurements of body composition utilizing rapid, inexpensive methods such as bioelectrical impedance or dual energy X-ray absorptiometry can provide more information on body fat percentage, sarcopenic obesity, and lean body mass, and can be tracked longitudinally. With a patient's course of treatment. 53 Complications of obesity. When overt complications of obesity such as hypertension, type 2 diabetes, hyperlipidemia, or coronary heart disease are diagnosed, these conditions should be treated concomitantly with medically supervised weight loss. Certain conditions such as osteoarthritis, OA, will usually improve as the patient loses weight, unless the severity requires joint replacement. Diabetes. Having a first or second degree relative with type 2 diabetes is an independent risk factor for insulin resistance, see earlier, but the risk of diabetes also rises as BMI increases and is particularly steep when the BMI is greater than 30 kg/m2. Weight gain in middle age, independent of total attained weight, increases both the risk of impaired glucose tolerance and the risk of heart disease. 54 Blood pressure increases linearly with BMI, and hypertension is present in approximately half of very obese individuals at initial evaluation. 55 Lipid derangements. Dyslipidemia, characterized by low HDL cholesterol and high TG levels, is more common in obese than in non-obese individuals, particularly those with central adiposity. 56 When accompanied by hypertension and an elevated serum glucose level, these derangements meet the National Cholesterol Education Program criteria for metabolic syndrome. 57 A meta-analysis of 21 cohort studies suggested that the adverse effects, EASE, of obesity on blood pressure and serum lipid levels account for roughly half of the excess risk for coronary heart disease in obese individuals. 58 Cardiovascular diseases. Because coronary heart disease accounts for nearly half of all deaths in our society, its relationship to obesity is particularly 96 Part 2 Nutrition in gastroenterology important. In one study, an increase in BMI of 1.1 kg/m2 increased the risk for major CVD by 6%. 59 Obesity also increases the risk of heart failure and atrial fibrillation. 60,61 Much of the increased risk of heart disease is associated with central adiposity. The 2004 Interheart Case Control study of more than 29,000 patients from 52 countries identified abdominal adiposity as 20% of the population's attributable risk for a first myocardial infarction. 62 Hypertension. Blood pressure is often increased in patients who are overweight or who have obesity. Obesity and hypertension interact with cardiac function. The combination of being overweight and having hypertension leads to thickening of the ventricular wall and a larger heart volume, and thus to a greater likelihood of cardiac failure. 63 In the Swedish obese subjects study, hypertension was present at baseline in 44% to 51% of subjects. 64 For each decline of 1 mm Hg in diastolic blood pressure, the risk of myocardial infarction decreased an estimated 2% to 3%. Kidney disease. Obesity may affect the kidney in several ways. Obesity-related glomerulopathy is defined as having a BMI greater than or equal to 30 kg/m2 and the presence of glomerulomegaly with or without focal segmental glomerulosclerosis on kidney biopsy. The incidence of obesity-related glomerulopathy has risen significantly, from 0.2% in 1986 to 1990 to 2.7% in 2001 to 2015. 65 Overweight patients are also at increased risk for uric acid and calcium oxalate kidney stones because of altered acid-base metabolism. 66 An increased BMI has been associated with the risk of end-stage kidney disease. In a study from the Kaiser Permanente group of Northern California, HSU, and colleagues found that a higher BMI is a progressively greater risk factor for end-stage kidney disease that persists even after correcting for multiple potential confounding factors, including baseline blood pressure or diabetes mellitus. 67 Gallbladder disease. Cholelithiasis is the primary hepatobiliary disorder associated with being overweight. The increased total cholesterol levels seen in patients with obesity are excreted in the bile, where high cholesterol concentrations relative to bile acids and phospholipids may increase the likelihood of precipitation of cholesterol gallstones in the gallbladder. During weight loss, the likelihood of gallstone formation paradoxically increases because the flux of cholesterol mobilized from fat is increased throughout the biliary system. 68 Diets with moderate levels of fat prompt gallbladder contraction, thereby emptying its cholesterol content and perhaps reducing the increased risk of stone formation associated with weight loss. Similarly, the use of bile acids, e.g., UDCA, may be advisable if the risk of gallstone formation is thought to be increased. 69 Liver disease. NAFLD is the term given to describe a constellation of liver abnormalities associated with being overweight and having obesity. This includes hepatomegaly, elevated liver biochemical test results, and abnormal liver histology, including steatosis, steatopatitis, fibrosis, and cirrhosis. See Chapter 87. Gastroesophageal reflux disease, GERD. Being overweight and having obesity are contributing factors in GERD, as illustrated by a 2014 meta-analysis of 9 studies, which showed a statistically significant association of GERD and BMI. 70 in another meta-analysis. The odds ratio for GERD was 1.43 in the overweight group, BMI, 25 to 29.9 kg/m2, compared with the normal weight group, and rose to 1.94 when the BMI was higher than 30 kg/m2. Erosive esophagitis and esophageal adenocarcinoma were also more common in obesity, with prevalence rates of 12.5% for BMI less than 25 kg/m2 compared with 26.9% for BMI greater than 30 kg/m2 for erosive esophagitis, and with relative risk ratios ranging from 2.27 to 11.3 in case control and cohort studies of esophageal cancer. 71 Cancer. Certain forms of cancer are significantly increased in patients who have obesity. Men with obesity have an increased risk for colon, rectal, and prostate cancers, whereas women with obesity experience more cancers of the reproductive system and gallbladder than women of normal weight. 72,73 One explanation for the greater risk of endometrial cancer in overweight women is the increased production of estrogens by aromatization in adipose tissue, which is related to the degree of excess body fat and accounts for a major source of estrogen production in postmenopausal women. 74 Breast cancer is not only related to total body fat but may also have a more important relationship to central body fat, which may help explain why breast cancer risk is increased at age 75 in women in the highest quartile BMI. Increased visceral fat as measured by CT shows an important relationship to the risk of breast cancer. 75 In the Nurses' Health Study, women who gained greater than or equal to 25 kg after age 18 were at increased risk of breast cancer, relative risk, 1.45, p.001. Women who gained greater than or equal to 10 kg after menopause also were at increased risk for breast cancer compared with women whose weight remained stable. 76 Obstructive sleep apnea. Increased neck circumference, greater than or equal to 17 inches in men and greater than or equal to 16 in women, enlarged floppy uvula, and tonsillar hypertrophy are predictors of obstructive sleep apnea, OSA. 77 Associated findings may include reports of snoring, disturbed sleep, irritability, and decreased libido. Laboratory studies may show polycythemia. Patients with daytime fatigue, sleepiness, and/or morning headaches should be screened with a diagnostic sleep study for OSA. OSA can be associated with further weight gain, and treating sleep apnea can facilitate weight loss, although the data are mixed. 78 There is evidence that treating OSA does not facilitate weight loss because of a reduction in overnight energy expenditure once OSA is treated. 79 Randomized control trials consistently identify that treatment of OSA will facilitate weight loss. 81 Mechanism in which treatment of OSA is thought to improve body weight regulation is through improved regulation of cortisol. 81 Diseases of the bones, joints, muscles, connective tissue, and skin. Osteoarthritis, OA, is significantly increased in individuals with obesity. The OA that develops in the knees and ankles may be directly related to the trauma associated with the degree of excess body weight, but the increased OA in other non-weight-bearing joints suggests that some components of the overweight and obesity, such as intramuscular fat infiltration and systemic inflammation, can alter cartilage and bone metabolism, independent of weight-bearing. 82 OA accounts for a significant component of the health costs of being overweight. Increased body weight also produces disability from joint disease. Several skin changes are associated with excess weight. Stretch marks, or striae, are common and reflect the pressure on the skin from expanding lobular deposits of fat. Acanthosis nigricans refers Chapter 7 Obesity 97-7 to a deepening pigmentation in the folds of the neck, axillae, knuckles, and extensor surfaces that occurs in many overweight individuals, Fig 7.1. The mechanism of acanthosis nigricans is thought to be due to activation of the insulin-like growth factor 1 receptor by high levels of circulating insulin. 83 Psychosocial dysfunction. Obesity is stigmatized in both children and adults, leading to psychosocial distress. 84 Overweight children have a negative self-image and also a significant decrease in their physical and social functioning compared with normal weight children. Overweight women appear to be at greater risk of psychological dysfunction compared with overweight men, possibly because of increased societal pressures on women to be thin. 85 Obesity and comorbid depression have a high prevalence. 86 Medical treatment of obesity. Dietary approaches in general, no dietary pattern of eating has been proven superior in clinical trials. Trials suggest that the diet that any given patient likes and finds easiest to comply with will produce the greatest weight loss for that patient. Low-fat diets, LFDs. LFDs are a common strategy to help patients lose weight, and most dietary guidelines recommend a reduction in the daily intake of fat to 30% of energy intake or less. In a meta-analysis of trials comparing LFDs, typically 25% of total calories from fat, with the control group consuming a regular diet, 30% to 40% of total calories, there was greater weight loss in the LFD group compared with the moderate fat group, 3 kg difference. 87 Low carbohydrate diets, LCDs. LCDs and very LCDs are more effective than LFDs for short-term weight loss but not for long-term weight loss. A meta-analysis of 5 trials showing superiority of LCDs for weight loss over LFD was not sustained at 12 months. 88 LCDs likely have other benefits, such as reduction in development of type 2 diabetes. The paleo diet is a variation of an LCD as it removes grains, in addition to dairy, from the diet. The paleo diet is not discussed further here as it is considered a fad diet similar to the Atkins diet. Meal replacement diets. A structured way to induce a calorie deficit is through liquid meal replacement. Meal replacements can be used in some patients to achieve further weight loss. This approach can be used in the short term, or as a partial liquid diet in the long term, such as 1 or 2 meals replaced by low-calorie liquid, protein shake, and the remaining meals as energy-balanced meals. 89 A common use of low-calorie liquid is perioperatively around the time of bariatric surgery, but it can be done for longer periods if a patient can adhere to it. 90 A simple approach to induce weight loss can be a meal replacement program with calorie-controlled individually packaged foods. Frozen low-calorie meals containing less than 400 kcal/package can be a convenient and nutritious way to restrict calories. Mediterranean diet, MD, for patients in whom cardiovascular health is a paramount concern, the MD can be suggested. There is no single definition of an MD, but these diets are high in fruits, vegetables, whole grains, beans, nuts, and seeds and use olive oil as an important source of monounsaturated fat. An MD allows moderate wine intake. There is low to moderate amounts of fish, poultry, and dairy products, with little red meat. The MD is associated with reductions in overall mortality, cardiovascular mortality, and cancer incidence. An MD may reduce cardiovascular events. In a randomized trial of 7,447 adults at high risk for cardiovascular disease, the two groups assigned to the MD supplemented either with extra virgin olive oil or mixed nuts had a lower rate of total cardiovascular events, stroke, myocardial infarction, cardiovascular death, compared with a control group, counseled to eat a LFD, hazard ratio 0.7, 95% CI 0.5 to 0.9, after 4.8 years. The absolute reduction in risk was approximately 3 cardiovascular events per 1,000 person-years. 91 Intermittent fasting long-term energy restriction leads to metabolic changes that make continued weight loss difficult. 92 Planned periods of negative energy balance during long weight loss efforts appear to mitigate metabolic adaptations to weight loss. This theory supports intermittent energy restriction, IER, as a way to stimulate weight loss or maintain a weight-reduced state. There are several models of IER that have been shown to be as effective for long-term weight control as a long-term balanced deficit diet. IER includes restricting caloric intake for a defined period of time and eating ad libitum, i.e., to satiety, during the non-energy restricted period. The most common form of IER is intermittent fasting, where caloric intake is severely restricted for short periods, often 2 to 4 days per week. The periods of energy balance, i.e., remainder of the week, may or may not have restrictions. Meta-analyses on IER conclude that it is an alternative, while not superior. Fig 7.1 Acanthosis nigricans involving the neck of an obese woman. Approach to chronic energy restriction for inducing weight loss. 98 Part 2 Nutrition in gastroenterology. Although some patients may demonstrate greater adherence, the data are equivocal on whether IER in fact mitigates the counter-regulatory mechanisms aimed at weight regain after diet-induced weight loss. 93 Pharmacotherapy. The National Heart, Lung, and Blood Institute of the National Institutes of Health recommends that for individuals who fail to respond to lifestyle interventions after 6 months of treatment, have a BMI of greater than 30 kg/m2, or a BMI of greater than 27 kg/m2 with a weight-induced comorbidity, weight loss medication may be added to their treatment plan. 94 The Endocrine Society has produced the first guidelines on pharmacologic treatment of obesity, including management of drug-induced weight gain. 95 These guidelines review the existing evidence for the FDA-approved and off-label medicines for weight management. In the setting of bariatric procedures, see Chapter 8, anti-obesity pharmacotherapy could be considered once patients reach a weight plateau and additional weight loss is needed to improve weight-related comorbidities, or if a patient presents with weight regain. In addition, it can be considered as a maintenance strategy following the use of a short-term bariatric procedure such as an intragastric balloon. 96 The goal of pharmacotherapy is not only to reduce weight, but, more importantly, to improve the comorbid conditions associated with obesity, such as hyperglycemia, hyperlipidemia, and atherosclerotic heart disease. Patients and physicians should appreciate that obesity is a chronic disease that will require long-term treatment. Patients should understand further that the efficacy of the current medication options is limited to 5% to 10% body weight loss in the majority of successful patients, but that more weight loss can be achieved when several approaches are used simultaneously. Physicians should know that all anti-obesity pharmacotherapy is classified as pregnancy category X and should not be used in pregnancy. Patients should be counseled on this. Phentermine/topiramate low dose, controlled release phentermine plus topiramate, as one capsule, was approved by the FDA in 2012 as a long-term treatment for obesity. Phentermine is an adrenergic agonist that promotes weight loss by activation of the sympathetic nervous system with a subsequent decrease in food intake and increased resting energy expenditure. The combination has been shown to have additive weight loss efficacy. 97 Phentermine/topiramate is available in 4 doses, 3.75/23 mg, starting dose, 7.5/46 mg, lowest treatment dose, 11.25/69 mg, or 1590 seconds milligrams. The majority of patients start on 3.75/23 mg and progress to 7.5/46 mg, with higher doses used if the medication is well tolerated and maximal efficacy is required. The highest dose is 1590 seconds milligrams. The FDA requires a risk evaluation and mitigation strategy to inform prescribers and females of reproductive potential about the increased risk of congenital malformation, specifically orofacial clefts, in infants exposed to phentermine/topiramate during the first trimester of pregnancy. 98 The most common adverse events, EAs, with phentermine/topiramate include paresthesias, dizziness, dysgeusia, insomnia, constipation, and dry mouth. Medication interactions include an increased risk of malignant hypertension with MAO inhibitors and increased probability of rise in heart rate and blood pressure if used with other sympathomimetic amines. The 52-week controlled release, phentermine plus topiramate combination on weight and associated comorbidities in overweight and obese adults, CONQUER, trial randomized 2,487 patients who were obese with a mean BMI of 36.6 kg/m2 and comorbidities including hypertension, dyslipidemia, diabetes or prediabetes, or abdominal obesity to either placebo, mid-treatment dose, 7.5/46 mg, or maximum treatment dose, 1590 seconds milligrams. Results showed 6.6% and 8.6% placebo-subtracted weight loss in the lower dose and maximum dose arms, respectively. 0.99 improvement in systolic and diastolic blood pressure (TGS) and greater increases in HDL were seen in obese and overweight subjects treated with phentermine plus topiramate compared with placebo in 2 phase 3 trials, the controlled release phentermine/topiramate in severely obese adults, a randomized controlled trial, and CONQUER trials. Improvements in fasting glucose and insulin levels were seen in the SEQUEL study, the 52-week extension of CONQUER, and a 54% and 76% reduction in progression to type 2 diabetes in the 2 treatment groups was noted in subjects without diabetes at baseline. 100,101 Lorcaseron, a selective serotonin 2C receptor agonist, was approved by the FDA in 2012 as a long-term treatment for obesity. Lorcaseron selectively activates the central serotonin 2C receptor over the 2A and 2B receptors and reduces appetite by binding to the 5-HT2C receptors on anorexigenic POMC neurons in the hypothalamus. Because of its selective agonism of the serotonin 2C receptor, lorcaseron reduces appetite and has been designed to avoid cardiac valvular effects, such as mitral or aortic valve insufficiency previously reported with fenfluramine, mediated through the 5-HT2B receptor. The development program has thus far excluded that possibility over 2 years, and long-term data are being collected in a 5-year cardiovascular outcome study. 102 The recommended dose of lorcaseron is 10 mg twice daily with or without food. There is also a new 20 mg extended release tablet to be taken once daily. The medication should be discontinued if greater than or equal to 5% weight loss is not achieved after 12 weeks. Lorcaseron is listed in Schedule 4 of the Controlled Substances Act. The most common EAs in clinical practice include headache, dizziness, fatigue, nausea, dry mouth, and constipation. There is a theoretical interaction with other serotonergic drugs. CO administration may lead to the development of potentially life-threatening serotonin syndrome or neuroleptic malignant syndrome-like reactions, although none were reported in the Phase 3 studies. Behavioral modification and lorcaseron for overweight and obesity management, Bloom, and behavioral modification and lorcaseron second study for obesity management. The Bloom trial included 3,182 adults who were overweight or obese and who received lorcaseron 10 mg BID or placebo for 52 weeks, in conjunction with diet and exercise. At week 52, all subjects were re-randomized to either placebo or lorcaseron for an additional year. At 1 year, the average placebo-subtracted weight loss was 3.6%, and 47% of the subjects taking lorcaseron lost greater than 5% compared with 20.5% in the control group. Subjects who showed a weight loss of greater than 5% in the first year and were maintained on lorcaseron treatment in the second year were able to maintain their weight loss better than those who had been switched to placebo. 103 The Bloom-DM study was conducted in obese subjects with type 2 diabetes. This trial showed that at 52 weeks, 37.5% of patients treated with lorcaseron 10 mg twice daily showed a weight loss of greater than 5%, which was more than twice the percentage in the placebo group. There was a reduction of HbA1c of 0.9% in those on lorcaseron compared with 0.4% reduction in the placebo group. 104 Chapter 7 Obesity 99 Bupropion/naltrexone 7 Bupropion/naltrexone was FDA approved for weight loss in September 2014. Bupropion's primary mechanism of action is as a reuptake inhibitor of dopamine and norepinephrine. Inhibiting reuptake of dopamine and/or norepinephrine modulates the reward pathway that various foods can stimulate. Naltrexone is a pure opioid antagonist that blocks an opioid pathway that may slow weight loss. The most common AEs of naltrexone SR/bupropion SR are nausea/vomiting, constipation, headache, dizziness, insomnia, dry mouth, and an increased risk for seizure. Medication interactions of bupropion/naltrexone include MAO inhibitors, used during or within 14 days of administration, opioids, opioid agonists, and opioid partial agonists. Abrupt discontinuation of chronic use of alcohol, benzodiazepines, barbiturates, or antiepileptic drugs may further increase the risk for seizure. Bupropion/naltrexone should be avoided in patients with uncontrolled hypertension, history of seizures, or if there is a recent history of bulimia or anorexia nervosa. A recent history of bulimia with excessive vomiting may result in electrolyte abnormalities and predispose a person to seizures, which would further increase a person's risk for seizure if on bupropion. Weight loss medication should not be given to a patient with a recent history of an anorexic eating disorder unless done with close coordination with the patient's psychiatrist to monitor for relapse. 4 56-week multi-center, double-blind, placebo-controlled trials, CONT-RAVE Obesity Research, or CORI 105 CORI 106 CORBMOD Behavior Modification 107 and COR Diabetes 108, were conducted to evaluate the effect of bupropion/naltrexone in conjunction with lifestyle modification in a placebo-controlled cohort of 4,536 patients. The CORI, COR2, and CORBMOD trials enrolled patients with BMI greater than or equal to 30 kg/m2 or overweight, BMI 27 kg/m2 or greater, and at least one comorbidity. The COR diabetes trial enrolled patients with BMI greater than 27 kg/m2 with type 2 diabetes with or without hypertension and/or dyslipidemia. The primary endpoints were % change from baseline body weight and the proportion of patients achieving at least a 5% reduction in body weight. In the 56-week CORI trial, the mean change in body weight was -5.4% in patients assigned to bupropion/naltrexone 360/32 mg compared with -1.3% in the placebo group. The clinically significant cutoff of 5% reduction in body weight from baseline occurred in 42% of treatment group patients compared with 17% of placebo patients in the CORI trial, 50.5% of the treatment group compared with 17.1% of the placebo group in the COR2 trial, and 66.4% of the treatment group compared with 42.5% of the placebo group in the CORBMOD trial. In the COR diabetes trial, 44.5% of patients receiving bupropion/naltrexone lost greater than or equal to 5% of their body weight after 56 weeks compared with 18.9% of patients on placebo, p.001. Patients using bupropion/naltrexone also showed a 0.6% reduction in HbA1c from baseline, compared with a 0.1% reduction in placebo. In all of the COR trials, secondary cardiovascular endpoints were met, including statistically significant improvements in waist circumference, visceral fat, HDL cholesterol, and triglycerides. Liraglutide 3.0 mg was approved by the US FDA in December 2014. Liraglutide is a GLP-1 receptor agonist that has been used for type 2 diabetes in doses up to 1.8 mg. In animal studies, peripheral administration of liraglutide results in uptake in specific brain regions regulating appetite, including the hypothalamus. A study involving obese individuals without diabetes demonstrated that liraglutide 3.0 mg/day suppressed acute food intake, reduced subjective hunger, and delayed gastric emptying. Conversely, energy expenditure in subjects treated with liraglutide 3.0 mg/day decreased, even when corrected for weight loss, which was probably reflective of metabolic adaptation to weight loss. 109 The scale obesity and prediabetes and scale diabetes studies evaluated the effect of liraglutide 3.0 mg on overweight and obese subjects with prediabetes and diabetes, respectively. Both 56-week, randomized, placebo-controlled, double-blind clinical trials illustrated significantly greater mean weight loss with liraglutide than with placebo, 8% versus 2.6% in scale obesity and prediabetes and 5.9% versus 2% in scale diabetes, p.0001. The efficacy of liraglutide in maintaining weight loss was examined in the Scale Maintain study. 422 overweight and obese subjects who lost greater than or equal to 5% of their initial body weight on a low-calorie diet were randomly assigned to liraglutide 3.0 mg daily or placebo for 56 weeks. Mean weight loss on the initial diet was 6.0%. By the end of the study, participants in the liraglutide group lost an additional 6.2% compared with 0.2% with placebo, p.0001. 110,111 GI symptoms, such as nausea, vomiting, and abdominal pain, were the most common reason subjects withdrew from the trials. 11 subjects in the scale obesity and prediabetes trial developed pancreatitis, 10 of 2,841 0.4% in the liraglutide group compared with 1 of 1,242 0.1% in the placebo group. None of the patients in scale diabetes or scale maintain developed pancreatitis. Increased rates of cholecystitis and cholelithiasis were also observed in all of the scale phase 3 studies, but it is unclear whether the cases were related to the medication or to weight loss. Although liraglutide is associated with improvements in blood pressure and lipids, it was found to increase heart rate by 2.0/min in scale diabetes. Liraglutide carries a black box warning on the association with medullary thyroid cancer in rodents, although the relevance to humans has not been determined. Therefore, liraglutide is contraindicated in patients who have had medullary thyroid cancer or who have a family history of MEN 2.112 or listed prior to 2012. The only weight loss medicine for long-term use was Orlistat, which was FDA approved in 1999. Orlistat promotes weight loss by inhibiting GI lipases, thereby decreasing the absorption of fat from the GI tract. Orlistat is not commonly used for obesity management due to the unpleasant ease of fecal urgency, oily stool, and fecal incontinence, but it may have a role as an additional medicine for a patient who is constipated on other anti-obesity pharmacotherapy. On average, 120 mg of Orlistat taken 3 times per day will decrease fat absorption by 30%. Mean weight loss after 4 years was significantly greater with Orlistat, 5.8 kg, than with placebo, 3.0 kg, p.001. 113 Investigational approaches. In addition to the 5 FDA-approved anti-obesity medicines, an increasing number of bariatric endoscopic procedures available for the treatment of obesity, i.e., endoscopic sleeve and intragastric balloons, there are several new pharmacologic compounds in clinical trials. An example of a centrally acting target in clinical trials is setmelanotide, which is an MC4R agonist being evaluated for rare genetic obesity syndromes. 114 Another example of an investigational therapy includes a GLP-1/glucagon receptor antagonist called oxynthomodulin. This combination has been shown to have an anorexigenic effect in studies. In addition, A device under investigation is the Gelesis hydrogel capsule that expands in the stomach, increases satiety, and may improve glycemic control. 115-100 Part 2 Nutrition in gastroenterology. The disease of obesity has become a global epidemic and is a major cause of other non-communicable diseases including diabetes, CVD, and cancer. Causes can be attributed to a combination of genetic, epigenetic, and environmental and lifestyle phenomena. Current treatments range from dietary and behavioral interventions to pharmacologic and surgical therapies in more severe cases. There are several new medical therapies with separate mechanisms of action that are in clinical trials as well as new devices. Management of obesity is evolving, and obesity is now viewed as a multifactorial chronic disease that needs to involve a combination of medical therapies and, when appropriate, interventional procedures. Surgical and endoscopic treatments of obesity are discussed in Chapter 8.